This is Dr. Stephen Harris. Pharmacology Section 3 will cover cardiac and renal pharmacology. In Chapter 1, we're going to talk about the important diuretics. The way you want to study diuretics is by looking at this diagram, identifying the site of action within the nephron where each of the diuretics is going to work. In fact, as we go through this chapter, what we're going to do is we're going to go in order through the nephron, talking about the different diuretics that work in each segment. Again, use the legend to identify the specific transporter that's being affected by our different diuretics. I want you to also use this picture. Notice in the proximal tubule that you have transporters for weak acids and weak bases. This is important as it relates back to a concept we covered in general principles related to ionization. We have transporters for weak acid drugs, for example. You might remember that I gave you a list of weak acid drugs that included loops and thiazide diuretics. Those drugs, being weak acids, can be filtered at the glomerulus, but they're also actively secreted in the proximal tubule. This is a transporter, though, not just for drugs. This is a transporter that transports other ions in the body, including uric acid. So when we think about the side effect of loops and thiazides causing hyperuricemia, this is the site of competition between the diuretic and uric acid. The competition leads to increased levels of uric acid in the blood, hyperuricemia, and possible gout. We also have a similar transporter for weak bases, and this can also allow for some competition. We're going to talk about two side effects on this slide, hypokalemia and alkalosis. I want you to think about these two side effects occurring simultaneously, especially as it relates to diuretics. Basically, if you'll remember the rule that in the kidney, potassium secretion is coupled to hydrogen secretion. So diuretics that are potassium wasting, and that's most of the diuretics, also tend to waste hydrogens. So if the drug causes hypokalemia, the metabolic disturbance that you're likely to see is alkalosis. But when you think about the handling of potassium in the kidney, remember, the most important part of the kidney for handling potassium is the late distal tubule into the collecting ducts. So as we get to that diagram, let's focus at that point on what's happening with potassium, and we can also explain what's happening with hydrogen loss. For now, go with the rule. Hypokalemia and alkalosis go together. Our first group of diuretics to explore are osmotic diuretics. The drug mannitol is the prototype here, and the drug is really the only true diuretic in the sense that it's going to simply attract water throughout the nephron. Some of its greatest actions, of course, are in the proximal tubule and in the loop of Henle, but really mannitol can attract water throughout the nephron. Most of our other diuretics, in fact, are going to block a sodium pump specifically. Mannitol, not blocking a sodium pump, just simply working with its osmotic effect. The osmotic effect of mannitol can be used in a variety of ways. In the eye, you can decrease intraocular pressure, and the drug is useful in glaucoma. It's going to increase the drainage of aqueous humor. It can also be used to decrease intracerebral pressure. Mannitol can be used in oliguric states like rhabdomyolysis, especially in a case where you have severe muscle injury. If you need to get rid of a lot of myoglobin, for example, mannitol can be useful in that situation. That happens sometimes in automobile injuries, crush injuries, where you damage muscle severely. Side effects: since you're giving this drug IV, there's a risk of acute hypovolemia if you give too much of the drug. In the margin is a clinical correlate about osmotic diuretics and their contraindication in CHF and pulmonary edema. These types of drugs are going to draw water from cells. They increase the filling pressures of the heart, and certainly they could exacerbate heart failure or situations where you have pulmonary edema. Next, we have carbonic anhydrase inhibitors. As we look at this group of drugs, this will be the first opportunity to start talking about sodium transporters in the nephron and how these drugs are specifically going to have their diuretic effect. Just to make sure you're looking at the diagram correctly, on the left side of the picture is the luminal membrane. So the left side of the diagram would be the urine side. There you're going to find a sodium hydrogen antiporter. It pumps sodium into the cells and hydrogen back into the lumen. On the right side of the picture is the basolateral membrane. So of course on the far right you're thinking about the blood. So in order to reabsorb sodium in this diagram, we're going to transport it left to right. Again, just to make sure you're looking at the picture correctly. On the basolateral membrane, you're going to find sodium-potassium ATPases, which are pretty much universal throughout the nephron. On the other hand, the sodium pump on the luminal membrane changes as we go to different segments of the nephron. If you think about targeting drugs for the proximal tubule, the most obvious target would be the sodium-hydrogen exchanger. Unfortunately, we don't have any drugs that specifically block that co-transporter. So what we have to do is get creative. We have to find a group of drugs that can indirectly interfere with the action of that pump, and that's what carbonic anhydrase inhibitors do. So the question really becomes, what's the significance of carbonic anhydrase in this pathway? If you go to the lumen, you see bicarbonate ions. You also see that they can form H2CO3, carbonic acid. Neither bicarbonate ions or carbonic acid can be directly reabsorbed through these cells of the proximal tubule. We need carbonic anhydrase because it can break down H2CO3 into CO2 and water. And there it is. CO2 and water easily move into the cells. But notice once we get CO2 and water in the cells, carbonic anhydrase found intracellular can help to form bicarbonate ions, which are reabsorbed, and also to form hydrogens, which are there to run the sodium-hydrogen exchanger. So if I use a carbonic anhydrase inhibitor, I'm blocking several processes here. I'm blocking the breakdown of H2CO3. Therefore, I'm preventing CO2 and water from moving into the cells, and I'm preventing the formation of hydrogens, and that's my diuretic effect. Without the hydrogens to run the pump, the sodium stays in the lumen, water follows sodium, and you have a diuretic effect. But you should also see the other very important consequence of this type of drug. Not only am I not able to form hydrogens, I'm not able to form bicarbonate ions, which means I can't effectively reabsorb bicarb, certainly not to the extent that I was doing before. So the bicarbonate stays in the lumen and is lost from the body. It should be pretty obvious to you what metabolic disturbance carbonic anhydrase inhibitor is going to cause, and that, of course, would be a metabolic acidosis. And it happens very rapidly. Within about 3 days of therapy, these drugs cause metabolic acidosis. When you look at the names of the carbonic anhydrase inhibitors, they all have a common ending, and that is zolamide. We have a couple of examples. Acetazolamide is a prototype that you should learn. In fact, I always recommend learn the prototype and the common ending. So acetazolamide and the other zolamides, with dorzolamide being another example. I've always been a big fan of looking at diagrams like we just went through on the previous slide, but if you're also a fan of reading the words, you've got the text that goes along with the mechanism. You must understand the mechanism of action for each of our diuretics. Let's look at the uses for carbonic anhydrase inhibitors, remembering that their use is limited by the side effect of metabolic acidosis. So glaucoma. These drugs can be given topically to decrease aqueous humor formation. The enzyme carbonic anhydrase has a role in the production of aqueous humor, so by blocking that enzyme, you decrease aqueous humor formation. And because you're applying these drugs topically, you very much minimize their side effect potential. A second use that I want you to look at is acute mountain sickness. When you climb above 10,000 feet, you're at risk for mountain sickness, and certainly you're at risk for hyperventilation. If we know that you're going to climb above 10,000 feet, what we do is we recommend that you take carbonic anhydrase inhibitors like acetazolamide as prophylaxis prior to the climb. It turns out that the acidosis produced by these drugs is actually protective from the development of mountain sickness. Let's see how many side effects you can predict that are going to happen with this group of drugs. The first one is easy. Bicarbonaturia, more bicarb in the urine because you're inhibiting the reabsorption of bicarbonate. Acidosis because of the loss of bicarb. Now, hypokalemia. You're going to have to hold on just for a second on this one. I said that most diuretics are going to be potassium wasting, so we can follow that rule right now. Most diuretics are potassium wasting, but we have to wait till we get to the collecting duct to explain exactly why you get the loss of potassium. You also can get hyperchloremia. This is really related to the fact that there's more bicarbonate in the urine, there's more of a negatively charged ion, and there's an attempt to reabsorb those anions later on in the kidney, farther down in the nephron. In fact, chloride is easier to reabsorb than bicarbonate, so it's almost like the bicarb can drive chloride reabsorption. It can possibly result in hyperchloremia. Paresthesias can occur. This is an action of inhibiting carbonic anhydrase in the CNS. Renal stone formation. This one is predictable. The fact that calcium phosphate stones are more likely to form due to an alkaline urine. And that's what these drugs are going to do. They're going to raise the pH of the urine. In fact, this is a good opportunity to have you think about possible test questions related to any diuretic and certainly to carbonic anhydrase inhibitors. A test question where you're given a series of arrows. Up-down arrow questions, I think, are always troubling for folks. In the case of carbonic anhydrase inhibitors, they might actually give you urinary electrolyte changes. They might give you blood electrolyte changes. They might give you changes in pH. And remember, what we change in one compartment, we're going to see the opposite in the other compartment. For example, since these drugs cause an acidosis, you would expect that blood pH is going to go down. But what happens to urine pH? Urine pH is going to go up. And in that alkaline urine, you're more likely to see renal stone formation. The final side effect is common to most of our diuretics, because most diuretics are sulfonamide derivatives. So if you're allergic to sulfonamides, there is cross-reactivity with many drugs, including carbonic anhydrase inhibitors. The next group we want to talk about are loop diuretics. They're going to work in the thick ascending limb. Once again, to make sure you're looking at the picture correctly. On the left side of the picture is the luminal membrane, where we find a sodium-potassium 2-chloride cotransporter. The purpose of that pump is to pump all three of those ions into the cell, and certainly that's the way that sodium is going to be reabsorbed, and there are various pumps, including sodium-potassium ATPase pumps on the basolateral membrane. In order to really explain some of the properties of loop diuretics, though, you have to go a little bit further in explaining the normal physiology of what's happening here. The actions of the sodium-potassium 2-chloride cotransporter. Obviously, one of those things is to bring potassium into cells. And when potassium comes into those cells, it accumulates to such an extent that some of the potassium diffuses back into the lumen. You see that in the diagram as a dashed line. And that back diffusion of potassium through luminal potassium channels causes a slight positive change in the membrane potential. And that's very critical, because the change in the membrane potential is the signal that opens up the paracellular space. When you open up the paracellular space, that allows for the reabsorption of magnesium and calcium. So if you understand the normal parts of the pathway, it's pretty easy to then place the loop diuretic on the diagram, have it block this sodium-potassium chloride pump, and explain what happens. So let's do that now. If I block that pump, sodium, potassium, and chloride stay in the lumen, and all three of those are potentially going to be lost from the body. But tell the rest of the story about potassium. If I block that pump, potassium doesn't accumulate inside the cells. If potassium doesn't accumulate, it doesn't back diffuse and change the membrane potential. Now what's the consequence? If I don't change the membrane potential, the paracellular space stays closed. And that means I cannot reabsorb magnesium or calcium either. So when you think about what loops are going to do, all of the ions shown on the left are potentially lost from the body. And while all of them are important, test questions many times go after calcium. They definitely want you to know what loops do to calcium. And so we've come up with this phrase. We say loops lose calcium. You know from looking at this picture that loops lose a lot of things. But certainly loops losing calcium can be very significant, very important for you. Now, is that always going to lead to side effects, or can there be therapeutic benefit behind loops losing calcium? Sure, there can be a benefit. If a patient has hypercalcemia, too much calcium in the blood, you want to lose that calcium from the body, and a loop diuretic would be effective at doing that. In fact, you would give that person IV saline plus a loop diuretic to treat their hypercalcemia. Of course, losing calcium could create some problems. Low calcium in the blood could certainly be a risk factor for somebody who's already predisposed to osteoporosis, so a loop should be avoided in that type of patient. Let's look at the individual drugs that are loop diuretics. Furosemide is our prototype. That is definitely one that you have to know. Torsemide, similar spelling at the end of the drug's name, and ethacrynic acid. Today, the two most commonly prescribed loop diuretics are furosemide and torsemide, but there is possibly one ethacrynic acid question waiting for you on the exam. We've already reviewed the mechanism of action of loop diuretics by looking at the figure, but it's also helpful to go back and reinforce the pathway that we discussed, and here's the slide that can help you to do that. When it comes to the uses for loop diuretics, we have a number of things that we like these drugs for. The first one, loops are the drug of choice for acute pulmonary edema. We can give an IV loop diuretic. It's a very powerful drug that works very quickly to get rid of fluid, very effective in the treatment of pulmonary edema. Also, these drugs are useful in heart failure. Many times we use them on an as-needed basis and use thiazide diuretics for more chronic treatment of heart failure, but loops certainly have a role in CHF. They have a very minor role in the treatment of hypertension. In fact, I would go ahead and give you this statement that if you're thinking about a diuretic for hypertension, thiazides are the most popular of the diuretics. Loops are rarely used, though we can see them occasionally used in combination for hypertension. Various types of refractory edemas are something that loops would also be useful for. And I'm going to skip down to the last one, which is hypercalcemia, which we explained on an earlier slide. Loops have a number of side effects, including the fact that they are sulfonamide derivatives. So with most of our loops, you can get cross-reactivity if you're allergic to sulfonamide antibiotics. But that doesn't happen with ethacrynic acid. So the statement that you can use ethacrynic acid in a patient who's allergic to sulfonamides, I think is the one possible test question waiting for you about that particular drug, because it's the least popular as far as number of prescriptions for the loop diuretics, but it's the most popular when it comes to that sulfa allergy question. Loops cause hypokalemia and alkalosis. Those are two side effects that we started this chapter with, and we said those two side effects go together. If we waste potassium, which these drugs do, they also cause an alkalosis. Again, stay tuned. We're going to cover that point specifically in a couple of slides. Loops lose calcium. Loops lose magnesium. So both of those can be side effects. Loops cause hyperuricemia. We explained this by looking at the diagram of the nephron a few slides back. Loops are weak acids. They compete for transport at that weak acid transporter in the proximal tubule. They compete with uric acid. So when the statement says actively secreted by the OAT, the organic acid transporter, that's the site of competition. So hyperuricemia and possible gout. Perhaps the most popular side effect question for loop diuretics, ototoxicity. All loop diuretics have this side effect. Maybe ethacrynic acid has a little bit greater risk, but since it's the least popular of all of them, watch out for furosemide or torsemide as the question on ototoxicity. I wonder, how many of you think you're going to have a patient walk into your office one day and say, "Hey doc, I think I've got ototoxicity"? See, it's something that people don't often say, they will describe, and that's what the test question will do. They will say that the patient experiences ringing in their ears, tinnitus. Perhaps the patient complains of what feels like fluid on their ears, sometimes described as a sense of fullness in the ears. You interpret that as ototoxicity, and if it was caused by a diuretic, you know that that would be loops. Another group of drugs that causes ototoxicity are aminoglycoside antibiotics. Certainly a patient who's on both an aminoglycoside and a loop diuretic has an increased risk of ototoxicity. Loops can decrease the clearance of lithium. Lithium is already a dangerous drug, a drug with a low therapeutic index. So when loops decrease the clearance of this drug, you can certainly increase the risk of side effects from lithium. Finally, with digoxin, you're going to see enhanced toxicity of digoxin due to electrolyte disturbances. We'll cover this point later on as we're talking about digoxin and heart failure, but for now, this relates to the loss of potassium. Hypokalemia is what's enhancing digoxin toxicity. In the margin is a note about allergies to sulfonamide-containing drugs. If you're allergic to sulfonamide antibiotics, you see cross-allergenicity with many diuretics. That includes carbonic anhydrase inhibitors, all loops except for ethacrenic acid, thiazides, and the drug celecoxib, a drug used for arthritis, a specific COX-2 inhibitor that's covered in a later lecture. So watch out for any of those drugs if you have a sulfonamide allergy. Next, let's talk about the action of thiazides. Thiazides are going to work in the distal convoluted tubule. The orientation of this picture is very similar to what we've seen previously. On the luminal membrane, that's where you're going to find your sodium pump. In this case, it's a sodium chloride cotransporter. And on the basolateral membrane, various sodium pumps, including sodium potassium ATPases, pump the sodium back into the blood. You'll also see that there's a pathway for calcium reabsorption. There are luminal calcium channels in the distal tubule, and there's a basolateral sodium-calcium exchanger, and this pathway is regulated by PTH. So what are the thiazides going to do? They block the sodium chloride cotransporter. By blocking that pump, both sodium and chloride stay in the lumen. Obviously, both are potentially lost from the body. But there is another action of thiazides that's a little bit harder to make a connection to. The action of the thiazide on blocking the sodium chloride pump seems to indirectly affect the action of the sodium-calcium exchanger on the basolateral membrane. In fact, let's just state it simply, and then we'll see if we can explain it further. If I block the sodium chloride pump with the thiazide, I'm going to increase the activity of the sodium-calcium exchanger. And the consequence of increasing the activity of that sodium-calcium pump is more calcium gets reabsorbed. That's the significant action. Earlier we said loops lose calcium. It's important for you to distinguish thiazides save calcium. They're going to enhance the reabsorption of calcium, putting more calcium back into the blood. Now you can think about that being beneficial for a patient who's prone to osteoporosis. More calcium in the blood certainly could be useful for that person. But the consequence of better reabsorption or greater reabsorption of calcium also results in lower levels of urinary calcium. So who could benefit from having lower levels of urinary calcium? Well, it would be patients who are prone to renal calcium stones. So nephrolithiasis is a potential use for thiazide diuretics. Exactly why thiazides enhance the activity of that pump is unclear. There's a theory out there that says that because we've got two different pumps that are bringing sodium into the cells of the distal tubule, blocking one enhances the activity of the other. But I don't want to go too far down that road. It's not the action of sodium that's the most critical thing here. It's what happens to calcium. So enhancing the sodium-calcium exchanger, the key point, more calcium gets reabsorbed. We have several thiazide diuretics, but hydrochlorothiazide has by far been the most popular drug. So HCTZ, is how you often see that drug abbreviated, has been the #1 thiazide by far for a long, long time. But I want you to watch out for the drug chlorthalidone. Recent evidence showing the benefits of chlorthalidone, especially in patients with hypertension, have become very, very popular topics to discuss. So watch out for this drug in the test question. It's a thiazide diuretic and it has the same action as hydrochlorothiazide. Indapamide would be a third drug. Sometimes you might get a question on this drug, but the first two, I would say, are way more popular. Also, we've discussed the mechanism. That is written out for you in the text on this slide. In the margin is a clinical correlate. I hope we've made this point very, very clear. I believe on a test question, you might be asked to identify a diuretic. The question may state that the patient was given a diuretic and you're going to have to pick what type of drug it is based on the profile, perhaps based on lab values that you're given. Loops and thiazides are going to look very, very similar. They get rid of sodium, they get rid of potassium, but one of the key ions that you use to distinguish the two is calcium. Loops lose calcium, thiazides save calcium. Uses for these very popular drugs include hypertension. In fact, they are one of 3 most popular drugs today as first-line therapy for hypertension. We'll discuss drugs for hypertension in a later chapter, but thiazides along with ACE inhibitors and calcium channel blockers today are the most popular options for initial therapy. Thiazides are also very useful for chronic CHF management. The second use, nephrolithiasis, renal calcium stones. Since we're going to reduce the amount of urinary calcium by pulling that calcium back into the blood, thiazides can be useful for renal calcium stones. I think the third use is the one that's the most challenging to understand. It's the fact that thiazides are the drug of choice for nephrogenic diabetes insipidus. So let's look at a vignette. In fact, let's look at a diagram that I've drawn to help us think about what's going on in diabetes insipidus. This condition comes in 2 types. There's central and there's nephrogenic. Now central, which is sometimes called cranial, neural, or neurogenic diabetes insipidus, all of that implies it's some problem in the CNS with ADH production. In fact, that's the real problem. If you have central DI, you don't have enough ADH being produced. The treatment of this condition is very straightforward. If you lack the hormone, give this person the hormone. So we give them a drug called desmopressin. You remember that the other name for ADH is vasopressin, so we use a vasopressin analog called desmopressin. It's just simply replacement therapy. With nephrogenic diabetes insipidus, the word nephrogenic tells us it's a kidney problem. In fact, the problem is with the receptors for ADH, and those are the V2 receptors which are found in the collecting duct. The V2 receptors don't respond appropriately, and since we don't have any way specifically to fix those receptors, we sort of have to circumvent the problem by treating with a thiazide diuretic. So first things first, drug of choice for nephrogenic DI, hydrochlorothiazide. Now here's why. If you've got diabetes insipidus, you are losing a lot of water. Your sodium reabsorption is occurring with no problem, but you cannot reabsorb water effectively because you can't respond to the actions of ADH. When you give this person a thiazide diuretic, it's going to block the sodium chloride pump in the distal tubule, causing the loss of sodium. Notice, they're losing sodium now, and they weren't losing sodium before. This is going to cause a drop in plasma volume, plasma osmolality, and it's going to trigger a compensation in the kidney for that sodium loss. And the best site in the nephron to compensate for sodium loss is the site where you get the largest amount of sodium reabsorption, and that's the proximal tubule. So the proximal tubule starts to reabsorb more sodium as a compensation for the action of your diuretic. When more sodium is reabsorbed, water follows sodium, and therefore urine output goes down. It's a real paradox, the fact that you can give somebody a diuretic and they actually urinate less. Now be careful, don't try this experiment at home. If you don't have nephrogenic diabetes insipidus and you take a thiazide diuretic, chances are pretty good your urine output is going to go up. But on the other hand, if you have nephrogenic diabetes insipidus, this is a very interesting action where a diuretic can reduce urine output. It's because of that compensation and more reabsorption of water as a result. When you look at the side effects for thiazides, several of these we've talked about or you could predict. For example, sulfonamide hypersensitivity, since that's a common side effect for most diuretics. Hypokalemia and alkalosis, 2 side effects that go together. Hang on, we haven't quite explained why that happens. Hypercalcemia. Thiazides enhance the reabsorption of calcium. That makes sense. Tell me again, why hyperuricemia? It's because thiazides are weak acids. They compete for transport in the proximal tubule with uric acid, leading to hyperuricemia and possible gout. How about the side effect of hyperglycemia? This is a side effect that if you think about what's going on with potassium, you could possibly explain why you get increased blood glucose with this group of drugs. In fact, I'm going to ask you to do one thing, which is to flip over to page 270 in your book. If you've got your notes in front of you, you can look at a diagram of the beta cell that's on page 270 in our book. And if you look at that figure, the very top of that figure are potassium channels. Let me remind you that the state of those potassium channels is typically open. Those channels are open, causing membrane hyperpolarization. That's how your beta cells normally exist. And when potassium channels are open and the membrane is hyperpolarized, you actually inhibit insulin release. So if I'm inhibiting insulin release, obviously I can increase blood glucose. In order to release insulin, in fact, we have to close potassium channels. When you close the channels, the membrane depolarizes. Calcium channels open up, calcium comes into the cell, and that causes insulin release. So what's the role of thiazides related to blood glucose? Thiazides get rid of potassium. And with lower extracellular potassium, chances are even increased that those potassium channels on your beta cells are going to stay open even more. You've actually increased the concentration gradient so the potassium channels stay open, and that inhibits insulin release. Blood glucose goes up. If you'll look at my clinical vignette on the slide, it reminds us that hypokalemia inhibits insulin secretion, whereas hyperkalemia can increase insulin secretion. I like to repeat myself, so as we cover diabetes in a later chapter, we'll talk about that same topic and those same side effects once again. The final side effect is hyperlipidemia. Most of our thiazides cause this side effect. Indapamide maybe is less likely to do so. And it's not exactly clear why thiazides can increase LDLs and triglycerides. Perhaps it's a secondary effect to the actions of this type of drug on insulin. But hyperlipidemia, nonetheless, is a side effect. In fact, I'll remind you now, tell you again later, we have two very important groups of drugs used for hypertension that both can increase your lipids. That would be thiazides and beta blockers. Neither of those are very good choices in individuals with hypertension and hyperlipidemia. In terms of drug interactions and cautions, we have to watch out for the interaction between a thiazide diuretic and digoxin. Similar to what we saw for lupus, this is related to the loss of potassium. We'll explain that, as I mentioned earlier, when we get to the heart failure chapter and talk about why digoxin's toxicity is enhanced when you lose potassium. You also have to think about the effect of thiazides on blood glucose and whether or not these are a good choice in patients with diabetes mellitus. You may avoid them. It's not an absolute contraindication, of course, but you may look for other alternatives, and certainly we have some good drugs for patients with diabetes and hypertension. I've got a clinical vignette that I want you to think about, and it's related to both lupus and thiazides. These drugs are the most common cause of hypokalemia and metabolic alkalosis. When you think about what your Step 1 exam is going to ask you, certainly they're going to ask you questions about the most common causes of things. So if it's a question on hypokalemia or a question on metabolic alkalosis, think about lupus and thiazides. In fact, if I see that metabolic alkalosis case on the test, you know what I'm going to think? I'm going to think about diuretic abuse. Why in the world would somebody abuse diuretics? Well, maybe you're thinking for weight loss purposes. You can think about people doing this kind of acutely. If you're a boxer, a fighter, if you're a jockey, if you're in certain positions where you have to make a certain weight in a short period of time. Maybe you're thinking, I'm going to get married one day. That's when I want to look my best. Maybe you take a lot of your diuretic because you know that water equals weight. So you're thinking loss of water, loss of weight, and the metabolic disturbance that produces, metabolic alkalosis. So watch out for that on the test. On the other hand, renal failure is the most common cause of hyperkalemia. We'll relate that point to a diagram in just a moment. Next, we're going to look at the very important action of potassium-sparing drugs on the collecting tubules. In fact, this picture here, I think, answers a lot of questions that we've brought up so far in our discussion of diuretics. So here we have principal cells and intercalated cells, two different cell types, each having their own important role. On those principal cells, you find luminal sodium channels. So sodium comes in through the sodium channel. Sodium potassium ATPase pumps that sodium back into the blood, just like we've seen in other parts of the nephron. Importantly, when sodium enters the principal cell, potassium is secreted through luminal potassium channels. Even though these are distinct ion channels, they are definitely coupled. Sodium in equals potassium out. So let's answer the question. Why are most diuretics potassium wasting? Can you figure it out? It's because most of our diuretics that work upstream of the collecting duct have already blocked the reabsorption of sodium. More sodium is coming down to the collecting duct. When more sodium shows up at the collecting duct, what are these principal cells going to do? They're going to attempt to reabsorb the sodium. In fact, their rate of reabsorption is going to be increased compared to normal because there's more sodium present. So what's the impact on potassium? More sodium reabsorption in the principal cell leads to more potassium secretion. Let's say it again. Why are most diuretics potassium wasting? It's because they increase the delivery of sodium to the collecting duct. Now let's go the other way. Do you remember the most common cause of hyperkalemia? It was renal failure. If you're in renal failure, how much sodium is being delivered to the collecting duct? The answer is it's not. So without the sodium being delivered to the collecting duct, there's no sodium coming in. So what does that mean? That means we retain potassium. Renal failure causes hyperkalemia. Diuretics, more sodium to the collecting duct, means more potassium loss. But we don't want to stop there with our story. We want to get these intercalated cells involved. When I secrete potassium from the principal cell, intercalated cells are electrochemically coupled, and they will secrete hydrogen at the same time. If you put the parts together, sodium coming into the principal cell results in potassium secretion and then hydrogen secretion. So potassium and hydrogen go in the same direction in the nephron. Diuretics that waste potassium tend to also waste hydrogens. So how did we start the chapter? With two side effects, hypokalemia and alkalosis. Two side effects that tend to go together. Now, if you're thinking, hey, that's a great rule, you should also be thinking about which group of drugs violated that rule. Which group of drugs did not fit that description? Who wasted potassium but didn't cause alkalosis? That's the carbonic anhydrase inhibitors. So I want you to explain two reasons why. Carbonic anhydrase inhibitor would not cause alkalosis. One is all the way back when you think about the proximal tubule. The fact that I'm blocking the reabsorption of bicarbonate. Bicarb stays in the urine. I lose bicarbonate from the body, and therefore I'm going to get an acidosis instead of an alkalosis. The second reason, look in those intercalated cells in this picture. You find carbonic anhydrase there. Carbonic anhydrase inhibitors not only work in the proximal tubule, they work right here on these intercalated cells, and they're going to block the formation of hydrogens. I've broken the coupling between potassium secretion and hydrogen secretion with that group of drugs. I still waste potassium because carbonic anhydrase inhibitors block the reabsorption of sodium. More sodium goes to the collecting duct, but I don't secrete hydrogens. So those two reasons, once again, loss of bicarbonate, and I'm blocking the secretion of hydrogen with a carbonic anhydrase inhibitor. But other drugs follow that rule perfectly. Loops, thiazides, waste potassium, waste hydrogen, hypokalemia, alkalosis. Therefore, it should make sense that if I can block the reabsorption of sodium in these principal cells, then I should retain potassium, and I should retain hydrogens. So if you look at the drugs amiloride and triamterene, those are sodium channel blockers. By blocking the sodium channel and blocking sodium reabsorption, I'm going to cause potassium retention. That's why they're potassium sparing, but they're also hydrogen sparing. So if you decided to eat the whole bottle of amiloride, what acid-base disturbance would you get? Metabolic acidosis. Because when I save potassium, that goes along with saving hydrogens. Hyperkalemia and acidosis go together. What about the other drugs in this picture? Spironolactone and eplerenone block aldosterone receptors. Talk about aldosterone for a moment. What does aldosterone do as a steroid? It binds to its receptor. The complex goes to the nucleus of these principal cells. Aldosterone encourages you to make more sodium channels and more sodium-potassium ATPase. So aldosterone wants you to reabsorb more sodium. Can you answer this question? If a patient has hyperaldosteronism, what acid-base disturbance do they get? Now you can close your eyes and see if you've memorized that or not. I would rather you open your eyes, look at this picture, and see if you can explain why hyperaldosteronism causes a metabolic disturbance. With more sodium reabsorption, what happens to potassium? More potassium is secreted. When I secrete potassium, what happens to hydrogen? More hydrogen is secreted. So I'm losing the hydrogens. If you have hyperaldosteronism, you get a metabolic alkalosis. So again, think about what you can explain by looking at this picture. If I block the receptor for aldosterone with spironolactone or eplerenone, I get the opposite. I have fewer sodium channels being produced, so less sodium comes into the cell. Therefore, I retain potassium and I retain hydrogen. So I've got two ways to be potassium sparing. I can directly block sodium channels with amiloride or triamterene, or I can indirectly block those sodium channels by reducing the number of sodium channels with spironolactone or eplerenone. Let's make a final point, and it's related to lithium. You notice that I've drawn lithium into this picture. Lithium is very, very similar in size and charge to sodium, and we believe that lithium can enter these principal cells through luminal sodium channels. And once inside the cell, lithium can specifically target the V2 receptor that I've drawn into the picture. That's that vasopressin type 2 receptor. And you might remember that one of the more common side effects from lithium is nephrogenic diabetes insipidus. Lithium gets into the principal cells, damages the V2 receptor, and you don't respond effectively to ADH, causing nephrogenic DI. Earlier, we talked about the use of thiazides in treating nephrogenic diabetes insipidus, and they're still absolutely considered the drug of choice, unless the nephrogenic diabetes insipidus was caused by lithium. You should come up with a better choice for lithium-induced nephrogenic DI. Block the entry of lithium into these cells with a sodium channel blocker, and we use the drug amiloride for that purpose. So amiloride is the drug of choice for lithium-induced nephrogenic DI. Let's look specifically at spironolactone, one of our potassium-sparing drugs. This drug is an aldosterone receptor blocker, but it's also an androgen receptor blocker. So there are two properties that you have to remember: blocking aldosterone receptors and blocking androgen receptors. And this is a way to distinguish spironolactone from the drug that's in your margin there, eplerenone. Eplerenone is just an aldosterone receptor blocker, but it doesn't block androgen receptors. And you can think of the good or the bad of that, right? By not blocking androgen receptors means you don't have any anti-androgenic side effects from eplerenone. Specific uses for spironolactone: hyperaldosteronism, of course, because it blocks aldosterone receptors. By blocking aldosterone receptors, it's potassium sparing, so it can be used as an adjunct to potassium wasting diuretics. It can also be used in congestive heart failure, and this is also related to its ability to block aldosterone receptors, and we'll talk more about that in a later chapter. But what about anti-androgenic uses, like female hirsutism? Obviously, that's because this drug blocks androgen receptors. Predictable side effects from this drug: hyperkalemia and acidosis. The fact that it's going to block aldosterone receptors and reduce sodium reabsorption means you're going to retain potassium and retain hydrogens. But because this drug blocks androgen receptors, while that's useful in female hirsutism, it can lead to anti-androgenic side effects like gynecomastia. Maybe a way to remember the name of this drug and that side effect is you can change its name to spironolactating. Maybe that's a way to remember the ability of this drug to cause gynecomastia. Our other potassium-sparing drugs are amiloride and triamterene. They're just sodium channel blockers and most often are used as adjuncts to potassium-wasting diuretics. But note the specific use of amiloride in lithium-induced nephrogenic DI. Side effects of these drugs are very predictable: hyperkalemia and acidosis. In the margin is a clinical correlate about combining potassium-sparing diuretics, ACE inhibitors, or ARBs. These are drugs that we're going to talk about in our hypertension chapter. But for now, let me remind you that ACE inhibitors and ARBs both are going to inhibit the production of aldosterone. With less aldosterone, you're going to have a potassium-sparing effect from these drugs. Therefore, if you combine them with any of our potassium-sparing diuretics, you've got to watch out for hyperkalemia. This table does a very nice job of summarizing the properties of our diuretics. Clearly, as we've discussed in earlier lectures, mechanism is important. So knowing the mechanism, knowing the specific sodium transporter that each of these types of drugs are going to affect, that's very key for you to know for your exam. You also see in the far right blood pH effects, whether it's acidosis or alkalosis, and you should actually be able at this point to explain why those things are occurring. But you'll notice you're always looking for maybe faster ways to remember things or perhaps shortcuts. No substitute, by the way, for understanding. But if you look at this, the diuretics that work at the extreme ends of the nephron, the one that works in the proximal tubule and the one that works in the collecting duct, those are the ones that cause an acidosis. And the ones that work more in the interior, kind of in the middle of the nephron, loops and thiazides, cause an alkalosis. But make sure you can explain why those things happen. Also look at the changes in urinary electrolytes. Sodium is easy. Potassium is going to be lost by most diuretics, except for those that are potassium sparing. And then, of course, final comparison between loops and thiazides, watch out for calcium.